Dear colleagues, welcome to today's working group webinar on Pulmonary Hypertension 2019, a roadmap for cardiologists. This is the second part of a webinar series of 2, which is provided by the ESC working group on the pulmonary circulation and right ventricular function. I am Professor Stefan Rosenkranz from the University of Cologne, Germany, and I have the pleasure of being joined today by Professor Irene Lang from the Medical University of Vienna, Austria, and by Professor Jean-Luc Vachery from the Erasmus Hospital of Brussels in Belgium. The aim of this webinar is to understand the key role of the cardiologist in the differential diagnosis and be able to recognize specific forms of pulmonary hypertension. And in today's part 2, we will focus on 2 specific pH subtypes. This session is interactive, and we strongly encourage you to actively participate by sending your questions and comments at any time during the webinar through the chat. For the best learning experience, we also invite you to participate in online assessment sessions in the form of MCQs that will be submitted during the presentations. I would like to acknowledge that this program is supported by Actelion Pharmaceuticals. I will now hand over to Professor Lang for the first case presentation, and Professor Lang will be presenting on a case of a young woman with dyspnea, highlighting the importance of correct diagnosis and interdisciplinary management. So Irene, thank you for being here and for sharing this case with us.
Good evening, everybody. Thank you, Stefan. This is a case of a young woman, and the question, are we able to cure her, is, I think, a very important question that you may ask with any case of pulmonary hypertension, particularly in young people. So here is my disclosures over the past 3 years. My case is a lady born 1982, a social worker who experienced papillary thyroid cancer in 2013. She underwent total thyroidectomy, radioiodine treatment, and then a high dose of thyroxine, hormone replacement treatment. She had some other surgery in the subsequent years, and in 2018 experienced acute PE, acute onset of dyspnea. And because everybody was afraid that she had iodine allergy, she underwent a VQ scan, and it definitely showed PE. A couple months after she had been on oral anticoagulation, and I looked it up, it was rivaroxaban, she experienced increasing dyspnea, couldn't walk anymore. And the question was, as she was a bit overweight, was it that, or was it thyroid hormones? Did she suffer from post-PE syndrome, which is a composite of several disorders after PE? It's some psychological symptoms. It could be some persistent thrombosis. So this is the question here. And she underwent echocardiography, she underwent physical examination. This is her presenting EKG at diagnosis, where you can see a normal axis deviation, a normal heart rate, sinus rhythm. Not much, except for, if you look close, there's some unspecific ST wave abnormalities in the precordial leads. We like to look at EKGs because they give a first clue. This is an EKG that's actually compatible with pulmonary hypertension, but no proof, of course. Blood tests were unremarkable, except for NT-proBNP, which was up. And this is a medical summary report that we had at the time of an outside hospital. She walked very little, 255 meters. She was also systemically hypertensive with a blood pressure of 180/100, and that she knew for a couple of years. Talked about the EKG. In the echo, right ventricular systolic pressure was estimated at about 60. She had good right ventricular function, but definitely signs of pulmonary hypertension. Normal left ventricular function with some left ventricular hypertrophy. Normal chest X-ray. And on repeat VQ, segmental defects, just like the ones seen in January 2018. What is your diagnosis at this point? Is it recurrent pulmonary embolism now that she is again dyspnea? Is it what I suggested, post-PE syndrome in a young patient who is still suffering from trauma of having had an acute PE after her cancer diagnosis? Is it IPAH now? Is this overlapping conditions? Or is it chronic thromboembolic pulmonary hypertension? Please vote.
All right, Irene, as we wait for the poll result here, I mean, you presented us different options here. A young woman who actually has risk factors for CTEPH and for pulmonary embolism. You mentioned the post-PE syndrome. Could you perhaps comment a bit more on that?
The new guidelines on acute pulmonary embolism, which were issued just this fall, they come with this new concept of taking care of patients after PE, which is really a relevant health problem. And the post-PE impairment syndrome, as this is labeled now, is both, as I mentioned, psychological sequelae, it's post-thrombotic syndrome, quite common, and it's also chronic thromboembolic pulmonary hypertension, which is rare.
Yeah.
So in the 3 to 6 months after the acute PE, the guidelines recommend to be seen by a physician and discuss, and then go on with more investigations if needed.
So I think this is a very important statement in the new ESC guidelines, and it's great that you bring that up here. So we have the poll result, and looks like a quite experienced audience here. 63% says it's chronic thromboembolic pulmonary hypertension, followed by post-PE syndrome, 20%. 14% believe it's IPAH, and only 3% voted for recurrent PE.
Well, this is very satisfactory. People are well educated, and we try to make the pulmonary hypertension diagnosis well seen and well diagnosed. And in fact, she had 2 risk factors for CTEPH. One is the cancer diagnosis, and one is the high-level thyroid hormone supplementation. So I'm really satisfied about this response. In fact, she did have pulmonary hypertension when assessed hemodynamically. And you see here that the PA was 42 mean, cardiac output still preserved, PVR around 580 dynes. And the ones of you who will watch this, I can actually replay. Note that there is a regular parenchyma, no effusions, no masses. It looks like actually normal. And if I show you the pulmonary arterial angiogram, the CT angiogram, it also looks quite normal. There's vessels everywhere. So we have the diagnosis of pulmonary hypertension, precapillary with a low wedge, and a high proBNP in a young woman after PE with 2 risk factors for CTEPH. Pulmonary angiography is the final diagnostic step, and you see here clearly segmental defects and a level 2 pulmonary obstruction at the A1 level, A2, A3 in the upper lobe, and it's a bit cut here. You see A10 is affected on both sides. It's very thin here, and there's a major defect in the upper lobe.
Can you perhaps comment on that distribution? Here it seems like it's mostly in the upper lobes. Is that typical?
Stefan, you have to also take into account the lateral views. And,
Absolutely.
And for diagnosis, this is key. And I've learned from Walter Klepetko, my surgeon, that he really sees most of the lower lobe segments here. The lower lobes are the predilection sites for the classical.
That's the reason why I asked.
Thromboembolic CTEPH. There are different distribution patterns in different etiologies. Arm vein thrombosis looks different. The pattern looks different. The classical picture is to have an A10 obstruction, and this is the case here. This helps also to differentiate to other etiologies like vasculitis or retroperitoneal disease, mediastinal disease, or tumor, for example. So the pulmonary angiography nails down the diagnosis, and I recommend that everybody in doubt, and there was a little bit of doubt, is performing this technique well. So the diagnosis is chronic thromboembolic pulmonary hypertension. It's in group 4 of the ESC classification. and is labeled here as PH due to pulmonary artery obstruction. The obvious next question is, and I'd like the audience to help me there, how would you manage? Young woman, peripheral CT-EPH, a tumor history. Would you do pulmonary endarterectomy first? Would you initiate medical treatment with the market-approved drug Riociguat first? Would you do balloon pulmonary angioplasty first because it's a segmental-subsegmental condition here, or would you combine? Please vote now.
So I guess we have to highlight here, and you did that, what is the first treatment option?
Correct.
This is the question.
Correct. And you could actually do them all at once in a hybrid room. This has been described. We have all the options today for the best of the patient. What's best for her? Please vote.
Well, and as we are waiting for the results, I just also want to remind the audience that you're able to ask questions online that we will see here. So please also submit your questions. Some came in already, so the audience seems to be quite active. But I encourage you to also submit additional questions that we will discuss here after these case presentations.
I mean, it's very clear that she's anticoagulated. I have to say that. This is not on the list because the diagnosis of CTPH mandates lifelong, efficient anticoagulation.
So perhaps, can you also comment, as you mentioned anticoagulation, about the time when you can make a diagnosis of CTEPH? Do patients have to be on anticoagulation before you make that diagnosis?
Right. Well, there's an arbitrary time frame put on the diagnosis, which is 3 months. There's actually no data for this, but to reassure that there is no subacute PE that is misdiagnosed as chronic thromboembolic pulmonary hypertension. This 3 months frame is dating back to the time of Ken Moser in the 60s when they saw their first patients.
So we got the result here, and based on the case you presented and the pattern that we have seen on angiography, the result is quite interesting. So 38% voted for all combined. 33% think medical therapy with Riociguat first would be the way to go, followed by pulmonary endarterectomy, that's 17%, and 13% believe that BPA should be the first option. So quite interesting result, I would say, and we can be curious what you did.
You know, Stefan, this reflects the evidence that is based on randomized controlled trials. I think the audience is well educated and they vote for what is really nailed down by clinical trials, which is Riociguat, of course. Although I would think...
Well, but the majority, and now it even increased to 40, I see here, says we should do all combined. And I find that quite interesting. And I'm curious now what you did.
Well, you know, we actually put together the CTEPH board, and this is a good idea. Shown here by the little chairs. It's a cardiologist, a pulmonologist, of course the thoracic surgeon. In my center is Walter Kepetko and his team. And there has to be an imager there. That's very important. And the patient advocate as well, who knows exactly who the patient is and what she's doing in this case, was very clear.
So I think in cardiology, we often talk about heart teams to make decisions.
Right.
And similar to our heart team, I think we really have to emphasize how important the CTEPH team is to address and to answer the question that you have just asked to the audience.
Right. And if you dissect the case, there is an argument for pulmonary endarterectomy, which is a mechanical treatment for a young patient with a relatively low 30-day mortality, probably 1 or 2%. There is an argument for balloon pulmonary angioplasty in the subsegmental location. And there's an argument for the medical, which is the likelihood of small vessel disease in her because of the associated conditions, which is cancer, of course. Microvesicles in cancer favor the small vessel disease component. So an argument for all three.
So what did the CTEPH team decide now?
The CTEPH team decided for surgery because the CTEF team has a very strong-willed surgeon who pointed out that the patient was young, had a very long lifetime ahead of her, and a low risk of surgical mortality. This is the pulmonary endarterectomy specimen, and I'd like to show you that the technique of surgery is dissecting the medial layer and harvesting all the medial and intimal material as a cast of the pulmonary arterial tree, which is seen here. This would be, you see there's something missing here, which is A10, but there is, of course, A8 is shown here, has been very nicely endarterectomized. So it's not like totally complete endarterectomy in her case, but they did what they could. She recovered well with residual pulmonary hypertension. We expected that. 34 mean, the PVR is halved, and well, not really halved. There's one third reduced. NT-proBNP is halved.
And can you explain why you expected in this case that you would have residual pulmonary hypertension in that particular case?
I'm very positive. I expected cure. When I saw the specimen, I expected residual pulmonary hypertension because of the missing segments, and the little tails were not perfect. Yeah. This is what you can predict from the sample.
And also when we look at the numbers here, cardiac output was actually reduced after PEA. That might be a matter of concern. Can you comment on that?
The reduction of cardiac output in the setting of a post-operative patient who has been on cardiac arrest, circulatory arrest, cardioplegia, etc., I think I would ascribe that to the cardiotoxicity of the procedure, and I would expect that this would recover over some longer time.
Irena, I have a question for you in terms of timing for reassessment. So 3 months, that's the timing you used. Would you consider letting the patient recover for a longer period of time, or like in mitral stenosis in the old times, we know that pulmonary circulation takes time to go back to normal?
That's a great question, and we do not know for sure, but the practice is 6 or 12 months. It depends on the center. In Papworth, it's more 12 months. In Vienna, we do it also at 12 months. Papworth actually has done 6-month studies as well. 3 months in this case was driven by the patient, who was not completely happy. And I tell you, the next generation is really demanding to be cured. They want to have the utmost of their treatment. So we compromised in this case and gave her an earlier appointment. And it was proven that she actually wasn't fully recovered. And you see on the angiogram here in the anterior posterior view that there is some lesions left. And stimulating additional treatments, of course. And we first started riociguat. I will show you. Well, I could actually explain to you that the upper lobe wasn't so bad, but the lower lobe definitely not sufficiently treated, as well as the left lower lobe here. And I will show you in a moment that we addressed the right lower lobe in her with BPA. You see here the guiding catheter coming in. Telescoped in this 8 French catheter is a smaller 6 French guiding catheter. And to reach down there to A10, we usually use what is called the guideliner, which is another guideline in guideline extension. So in the big Europeans, you need to get to the end of the vessel, basically. And the schematic of BPA is shown here, where a balloon is advanced over the wire to the distality of the pulmonary arterial tree. It's all major vessel pulmonary arteries. And then breaks the webs and bands that are obstructing. What is not completely correct in this graph is that the webs and bands are usually at the bifurcation. They're not in the middle of the vessel. But this is a fine detail. If I had drawn this, I would have placed it here. And we actually, this is a very nice representation of this bifurcational problem. I took out the graph and show you the real thing on this angiogram. You see the wire is still there. Run it. Here we go. This is after the dilatation. The wire still hangs in the vessel, and the flow is restored. And what is nice here is you see that it's bifurcational. Everything in the distality is gone. And this makes it very successful, I think, in this case. So, taken together, all hemodynamic assessments, you see here the baseline, the 3 months after, and then after 1 BPA and Rheosig water is a lot of improvement. You see the mean goes from 34 to 24, the cardiac output goes up to close to normal levels. PVR, of course, reduced, and proBNP is already normal, which I think is interesting, and also, of course, reflects the patient's activities. You know, if she exercises more, it's higher. Cardiac output subsequently goes up to almost 7 liters, right, which is normal. Mean pressure to 19. She's happy, running around with a low BNP, and sending me pictures. So. In summary, I think the audience is quite correct. We have used all 3 treatment options. But what does this case really tell us in terms of take-home message? It tells us that we still have a problem to diagnose. This is very open and honest. When I first met her, I didn't know her problem. So diagnosis and management of CTEPH are challenging and should be at least supported by expert center and by the CTEPH team. PEA, BPA, and medical treatments may be used complementary and lead to what can be called cure. And this is an image such as the ones she sends me from any mountain in Austria. Mm-hmm. So I'm really happy with her.
Great, Irene, thank you very much. And I think this case has very nicely illustrated the interdisciplinary approach that we need. You mentioned the CTEPH team, and you also mentioned the necessary members on that team to make good decisions in the end. And obviously, you need a lot of experience to interpret all the images that you can get and then to make decisions about treatment options. We have a couple of questions here. One is, I just want to keep this short, would you do thrombolysis in this patient if surgery is not available? And I think here we have to highlight, this is not about acute pulmonary embolism, it's chronic lesions that we have, so thrombolysis in such cases would not be an option because we're not talking about acute PE, and you went back to these images here.
Well, this gives the answer.
Yes, I think that very nicely gives the answer.
There is no red clot there.
Yeah.
What is down here is just some staining from erythrocytes. This is a case of chronic obstructive fibrotic tissue that would not respond at all to thrombolysis. There is cases with a combination of red and white, and they improve a little. Sometimes thrombolysis is life-saving in these patients in the acute phase, and as we learn from PITO and as we will learn from the FOCUS trial, some acute PE is CTEPH and gets thrombolysis and doesn't recover. So the answer to the question is thrombolysis takes care of the red material.
Exactly.
If there is no red, there is no thrombolysis.
Right, but we don't see the red on the imaging. But related to that question, we may highlight also the importance of acute on chronic pulmonary embolism, which may also be the case in certain patients. And this, I think, is an ongoing debate, and we'll also see new radiology rules.
Well, acute on chronic is CTEPH.
It's CTEPH to start with, but there may be instances where you have acute pulmonary embolism on top of CTEPH. I guess that's fair to say.
Right.
Another question is here, and that I think that reflects the sequence of therapeutic interventions here. You very nicely pointed out we have surgery, we have BPA, we have medical therapy, and they have evolved and developed over the years. So 15 years ago, surgery was the only option that we had. Now we have approved medical treatment, and we have BPA even further emerging. And the question here is from the audience, if the PVR would have been very high, would have would that have changed the sequence of the treatments? Would you have perhaps started with medical treatment to get the PVR down before you do surgery? Can you comment on that?
That's a great question. So there is a current randomized controlled trial underway testing preoperative Riociguat against placebo before pulmonary endarterectomy. And we will learn from that study if pretreatment is improving outcomes after pulmonary endarterectomy. Currently, we don't have any of these data. I think a high PVR, particularly above 1,000 dynes, according to the literature, would make a difference to the sequence of how we would treat this patient, although surgeons become very brave, particularly in young females. And I think my surgeon would still have gone in and performed pulmonary endarterectomy. In particular settings where the PVR is exaggerated, 1,600 dynes, surgeons do not prefer to do this case, and then I would have been doing balloon pulmonary angioplasty in small steps, according to what I was taught, with small balloons, several rounds, up to 10, 15 sessions. And that would have been probably similar results, hopefully.
Perhaps one comment, Stefan and Irene. The risk I see with pre-treatment with medical therapy is the potential delay of PE and having patients having some sort of improvement and then turning down surgery because they do feel a bit better. So I view this as a risk. You very nicely shown that there's a treatment for each part of the pulmonary vesicle, from the proximal to the very distal. I think from a patient perspective, we need to be very clear on what is the preferred combination, the preferred sequence of
and that decision must be made by the CTEF team.
Definitely.
And no one else.
Right.
Yep.
Because then we wouldn't have that delay.
Yep.
There may be good reasons to start with medical therapy,
Absolutely.
but as you said, that should not delay the time to surgery. And now one of our colleagues asks about the PEA bridging study.
Yeah.
Can you briefly comment on that?
The PEA bridging study currently enrolling is designed to test the value of Riociguat 3 times 2.5 up-titrated against matched placebo 3 months prior to pulmonary endarterectomy in a group of high-risk patients with CTEF, and that high risk is defined by PVR greater 800 dynes.
And I think we have great questions here. What about small emboli in distal branches found incidentally in CT scans? Are they clinically important?
That's an acute PE question, and that brings up the whole dilemma of excellent imaging, and the treatment has to always be put into perspective of the patient case. And you would treat if there is symptoms, of course, if there is a high risk of recurrent thrombosis. You have to take the whole picture.
But I think it's not necessarily an acute PE question, because sometimes we may see very little perfusion defects versus severe pulmonary hypertension. So then you may ask yourself in this context, is it really CTEF or is it perhaps PAH?
Well, in that, if you turn the question this way, I recommend to do intravascular imaging. This is the case for intravascular imaging, where you go in with an OCT probe and you look in A10, and if A10 is webbed, CTEF, or maybe chronic thromboembolic pulmonary vascular disease if there's no pulmonary hypertension, whatever you might want to call it.
I think that's also an important issue
maybe.
that we didn't really touch upon here, but improvement of diagnostic tools. You mentioned OCT, there are other things coming up as well. So this will, I think, further improve our diagnostic.
Right. It's for those particular cases that I would use OCT. Otherwise, it's not necessary.
Okay. Then there is another question about anticoagulation. What would you do to prevent future events in such patients after surgery or after BPA?
The guidelines recommend lifelong anticoagulation, Stefan. And because CTEF is not a factor 10A disease, but a broad inflammatory thrombotic problem, we know for antiphospholipid antibodies, we know about elevated levels of C-reactive protein, etc. So pointing all to the inflammatory disease, pathophysiologic disease state, The more broad anticoagulants like vitamin K antagonists are probably recommended.
Although we see an increased usage of NOACs as well, and I think it's not forbidden, and we don't have solid data for that.
We don't have data, but we have some rationale for vitamin K. I would plead for vitamin K, but I recognize there's no data out there to justify that.
Perhaps one last short question, short answer, please. How often can we miss PE on CT? I think that's also
very rarely. I think CT is a very advanced technique. Unless you do it technically incorrect, it has a very high specificity.
For acute PE.
For acute PE.
But in this case, where we talk about chronic PE, I guess that's an important...
For the chronic condition, as you saw in my case, CT may miss small pulmonary artery occlusions, particularly if it's not set out to detect CTEPH. And I think there is a lot ongoing in terms of artificial intelligence-based CT scans where CT will get even better. I have a high confidence in CT, but still today, with a regular sliced CT scan, you may miss CTEPH still.
And I think it's okay to remind the audience that the sensitivity for detecting chronic pulmonary emboli
is lower than for acute.
It's very low. It's roughly 60%. That's what the data say. But as you mentioned, it will improve. And also we have dual energy CT and iodine imaging and so on that will improve also this
Definitely in the
methodology.
studies that are published, the sensitivity is, the specificity, the sensitivity is higher than 60%.
But
already.
I guess in clinical practice, the guidelines today recommend to perform VQ scan as you have shown, and when in doubt, we have to do that to really rule it out, at least as of now.
Yeah.
Irene, thank you very much. Very interesting case that you presented, and this really highlighted all the things that we talked about. So thank you indeed, Irene. And then we'll move over to Brussels. Jean-Luc, you will now present us a case on PH in left heart disease. So we're now talking about probably the most common cause of pulmonary hypertension due to left heart disease, whatever that means. And you called it road-blocked ahead. I'm curious.
Yes, thank you, Stefan, and colleagues. Thanks for joining us. Blocked ahead, and you will see why in a couple of minutes. I agree, this is the most common cause, and this is probably the one we're the most struggling with, especially when pulmonary hypertension arises as a complication of heart failure with preserved ejection fraction. So here are my disclosures. I want to tell you the story of Claudine. She was born in 1948. She's a farmer. She has cereals and cattle. She was a heavy smoker, 75 packs per year since 1965. So she started quite early in her young ages. In 1996, she was diagnosed with severe obesity. A BMI was over 40 kilograms per square meter. She received one of the Belgian specialties that's called a pot belge for a total of 2 years. It's a combination of thyroid extract, furosemide, beta blocker, and fenfluramine. So clearly, this is something that is supposed to be sufficiently anorectic to help her lose weight. It didn't work out that well. She was diagnosed then in 2010 with diabetes, hypertension, dyslipidemia. And then in 2012, her medical history calls for an episode of paroxysmal atrial fibrillation that recovered spontaneously. Then the story starts to be a little bit more tricky. In May 2017, during orthopedic surgery, she had a hip replacement. She suddenly had, in perioperative period, hypoxemia, and at the same time she was diagnosed with acute PE, paroxysmal atrial fibrillation, again spontaneous recovery, and echocardiography that was done at that time revealed two things. One, elevated PA pressure or suspicion of elevated PA pressure, 50 millimeters of mercury of systolic, and a patent foraminovaly at transesophageal echocardiography. She remained quite symptomatic for 6 months, and she went back to the clinic at another institution in December. When the workup was done again for what was called unexplained dyspnea, you can see here the results of the initial workup. NT-proBNP just above the limit. She's an obese patient. The summary of the echo, and I would like to insist of what was written in the summary, the estimated right ventricular systolic pressure was 60, no signs of RV strain, normal LV function, and it was called to be worsening of pulmonary arterial hypertension, and we'll come back to that in a minute. Transesophageal echo was controlled. She had an aneurysmal interatrial septum, and indeed the PFO was present, but only during the Valsalva maneuver. She had no PFO on spontaneous breathing. The chest X-ray, angio-CT, PFTs were reported within the normal value, and she was able to walk about 400 meters at the 6-minute walking test. Then she went to the cath lab, and this is what we got. This is the report, and literally this is what we found on the report. The mean PA pressure was measured at 33 millimeters of mercury, the wedge pressure at 15. There was no report on right atrial pressure, cardiac output, and PVR, and there was no vasoreactivity testing that was performed at that time. The diagnosis that was put forward by our colleagues was PH associated with anorectic drug intake, because she had that history of 2 years of intake of at least one drug that is associated with PH, which is fenfluramine. She was treated with monotherapy with an endothelin receptor antagonist, and that was the treatment when she left the clinic. Unfortunately, after 6 weeks of that treatment, she went on severe fluid retention. She gained 5 kilograms. She was really getting a peripheral edema, significant pulmonary edema. There was no clinical improvement after 3 months of treatment. She has persistent functional class 3. She had also a new onset of atrial fibrillation, more or less 3 months after the initiation of the treatment. And at that time, she received electrical cardioversion and the control of echocardiography. And again, I'm putting here what was written on the report. It was persistent pulmonary arterial hypertension with high estimated right ventricular systolic pressure at 70 millimeters of mercury, and no report on the performance of the right heart. Then she was sent to us in April last year. First contact, persistent fluid retention, functional class 3. Her medical treatment ongoing included 3 antihypertensive drugs, 2 lipid-lowering agents, 2 oral anti-diabetic drugs, 1 endothelin receptor antagonist, aspirin, and no diuretic. At the time she was at the clinic, she was on and off on furosemide once in a while, but she was not constantly put on diuretics. So the physical examination we did confirm obesity. BMI was at 38 kilograms per square meter. She had high blood pressure, and unsurprisingly, she had bilateral swelling up to the knees with pitting edema. So she was really obviously not properly decongested at the time we saw her. Initial workup, non-invasive at the outpatient clinic. This is the ECG that was quite unremarkable. So were the blood tests. There was nothing to look at. NT-proBNP, however, was higher than was previously reported in sinus rhythm, 850 picograms per milliliter. But of course, remember, the patient obviously has significant fluid overload. She went to the echo lab, confirming normal LV function, normal right ventricular function, no pericardial effusion. She had mild aortic sclerosis with no stenosis, but she had an enlarged left atrium. The volume index was higher than the upper limit of normal. The estimated systolic PA pressure was at 60 millimeters of mercury. E ovary prime, 15, suggesting that filling pressure might be high, and cardiac index was at the lower limit of normal calculated by echocardiography. And I'm putting here the summary from the echo examination, and this is something we really like to see. We like to see the sonographer telling us what is the echocardiographic probability of pulmonary hypertension. In this case, it was high. Normal index of RV function, normal LVEF, and signs of increased left atrial volume index and possible increased in left ventricular filling pressures. Now, I would like you to help me to manage this patient appropriately, and I'm asking you, how would you do it? So one option would be no change. One option would be to give her diuretics on the long run, constant dose. One would be to give diuretics, then escalate therapy with PDE5 inhibitors. BNP is going high, PA pressure, estimated PA pressure is getting higher. And the fourth option would be to give her some diuretics, stop the endothelin receptor antagonist, and then reassess the patient after you've done your first call for treatment. So these are the options that actually were discussed with a junior colleague that was with me at the consultation at that time, and we were chatting in front of the patient and explaining the various options here that I'm putting forward for the vote.
But he had a great teacher, so...
Yes, thank you for saying that. He's very happy with that. Yeah.
So let's see what the...
I'm really surprised because the first thing patients do when they cannot breathe is take diuretics. And she actually didn't.
No, she was on and off, and she didn't receive any instruction to keep the diuretic regimen on during the time she was between two institutions.
Because this is a blessing, almost, you know, because some are harmed by it.
So we have a very interesting result here. So no change, 0%. Obviously, this patient wasn't doing well, so doing nothing was not an option. Diuretics, 8%. And then 37% says start diuretics, stop the ERA, and then reassess. And the majority of the audience said give diuretics and escalate therapy with the PDE5 inhibitor. I'm sure, Jean-Luc, this will keep you going here.
Very much so. I'm getting a bit nervous.
This is your lobby.
I mean, this is a question we receive quite often. You know, patients have high pulmonary hypertension, high PA pressures. They have those signs of right heart failure or congestion, and immediately people think, oh, let's give PDE5 inhibitors. And by the way, it's safe. And in fact, it's not safe. This is, of course, not what we did. And the reason is that, if you recall, we're missing a lot of information from the initial right heart cath, and we have a clinical presentation that looks at the left side instead of the right side. So what we did is to stop ERA. We did a workup in June, so 2 months after, while she was on diuretics for 2 months with a combination of furosemide and spironolactone. And in fact, as Irene pointed out, she was very happy with that because she lost weight, her BMI went down, she had decreased swelling that was limited to the ankles, the blood pressure was much better controlled, the heart rate was at 60 beats per minute in sinus rhythm, so the patient was already feeling better with this treatment regimen. We did some complete workup. Of course, we added pulmonary function test and arterial blood gases, and I would like to highlight what is seen in red here. Although the volumes were within the normal range, except for the FVC that was 121% of predicted, the DLCO was low, was 40% predicted, and this is an important marker. It may be a marker of pulmonary hypertension, it may be a marker of HFpEF, but this is something very unique that we need to check in all our patients.
Jean-Luc, it could also be very independent from pH and from HFpEF. I mean, some of us view this as potentially an own entity, own disease of the small pulmonary capillaries.
Yes.
That will put additional burden on the patients. And we have seen data from the Hanover group in patients with PH and HFpEF showing that this is even predictive of survival if you have PH, HFpEF, and a low DLCO. So it's important, but probably we are not able to understand it properly at present.
So the physiology of it might be difficult to understand at this stage, or at least to explain, but the thing we can tell already is that if this is a case of pulmonary hypertension due to left associated with a HFpEF syndrome, which is possible, you have an involvement of small pulmonary vessels. So you have a disease, or let's say changes in the arterioles, small arterioles, but also small venules, and that might be a marker of venular impairment rather than arteriolar impairment. So this is something we need to keep in mind. Although we don't understand it, it seems to have prognostic implications in those patients.
May that even be in this context like a PVOD phenotype?
It's one of the options. Indeed, you will see what we come up with. Hypocapnia 31, no significant hypoxemia at the time. This is the chest X-ray and the VQ scan. The VQ scan excluded pulmonary embolism or let's say chronic thromboembolic pulmonary hypertension. At least it's completely normal. VQ, ventilation and perfusion are perfectly matched. Chest CT, high-resolution CT scan, rules out any lung abnormality. There was no emphysema, no fibrosis, no septal line. A couple of ground glass opacities, back to what you were saying about potential for PVOD. The absence of septal line, though, what was pretty much excluding that diagnosis in this case. She had bibasal bronchiectasis because she was a heavy smoker. Functional testing was quite interesting. The walking distance was 410 meters, which is quite okay for this more than 70 years old lady with obesity. The peak heart rate, 101. There was no significant desaturation, although the oxygen saturation dropped to 90% from 94%. CPET is interesting. There was a good ventilatory reserve. Peak VO2 was decreased at 66% predicted. So was peak heart rate. 69% predicted with a high VV2 slope, showing that this patient is hyperventilating during exercise with an RER of 1.07. So there's clearly here a cardiac and partially at least chronotropic limitation that is due to the fact that one of the treatment that she's receiving is a beta blocker for systemic hypertension. The other is diazepam. So there are two reasons why the heart rate was not reaching the maximum.
Which may be a problem because we have learned that in HFpEF,
yep.
Patients may be more symptomatic if you give them beta blocker,
yes.
potentially because of that reason.
Totally agree with you, of course. Of course, we brought her to the cath lab, and this is what we got. So at the time she went to the cath lab, she had very minimal swelling at the ankle level. Her jugular vein was not distended. There was no hepatic reflux. The mean PA pressure was at 39 millimeters of mercury. The wedge pressure was at 20 millimeters of mercury. The right atrial pressure was still at 12. Be careful, the scale is different between the PA wedge pressure and the right atrial pressure measurement here. So we could have done probably slightly better in terms of diuretics, but nevertheless, this is what we got at the time of stability at the cath lab. Again, ARA was stopped, and she was on full dose diuretics at the time we did it. Clearly, this patient has a left heart disease phenotype. She has a lot of risk factors, cardiovascular risk factors. She has a lot of risk factors for heart failure with preserved ejection fraction. So we went left. We did LVDP measurement, was at 18 millimeters of mercury. We also did a coronary angiogram at this time. At the same time, that was reported to be completely normal. This is just a wrap-up of the invasive assessment of the patient. There's a typo in the title. PVR 3.6, DPG 7, mean PA pressure 39, wedge pressure 20, LVDP 18 millimeters of mercury. So this was the hemodynamic assessment that was done in this patient in a steady state. So now I'm asking the question back, and I hope we will discuss the management afterwards. Colleagues, what is your diagnosis with this? Do you believe it's still pH associated with anorectic drug intake, group 1? Do you believe it's pulmonary hypertension due to lung disease, group 3? Do you believe it's unclassified, group 5, because there's a lot of risk factors for pulmonary hypertension? Or do you believe that this is pulmonary hypertension due to left heart disease, group 2, because of the hemodynamic phenotype that was clearly post-capillary? Curious to see if people have changed their minds, and then we will go back to this idea of escalating treatment.
Okay.
Everybody will know. I think the 100% will know.
Let's see. You didn't mention group 4 here because obviously you
yes.
have ruled it out, but
Very
still
important.
I want to just bring up the question. This is post-capillary pulmonary hypertension, but yet it could still be CTEPH, the case we have seen before. Yeah. Just from the hemodynamic profile, I think it's important when we think about, is it PAH, is it group 3, is it group 2 yeah. in such a case?
Yeah. She has a history of venous thromboembolism.
Absolutely. Right.
But you have ruled out.
Ruled out, VQ scan normal. I mean, you said, we mentioned and we discussed the power of angio-CT. In this case, it was, I think it was clearly ruled out.
Okay.
Yeah.
So I know the Paul results.
Okay.
And you don't so far.
Nope.
But you will be quite happy with it. The vast majority now says it's PH due to left heart disease. Group 2, it's 80%. 12% think it's unclassified PH. And then 9 and 4% are voting for 1 and 2. So the vast majority now says it's PH due to left heart disease.
Yeah, that's. I mean, it's good. It's a very good change from the first impression, and it really highlights how important it is to have a big picture when we do an assessment for pulmonary hypertension, especially when there are cardiovascular risk factors. So, indeed, this is the final diagnosis that we would hold on to. This patient has heart failure with preserved ejection fraction. This is probably the best matching diagnosis. She has major criteria, clinical features, risk factors, and high probability based on non-invasive or pre-test or pre-cath probability. It's confirmed by increased wedge and LVEDP. Both of them were elevated. I would like to highlight two other criteria that I find interesting to mention. One is the low DLCO. We already discussed that. It's part of the picture, although I agree it might be a different entity, but still, it's a hallmark of pulmonary hypertension due to left heart disease, and it might have prognostic implication. And the second is fluid retention on ERA. This is something that we do see.
And here's a question from the audience. What is the mechanism behind worsening with ERA?
Yeah.
Do we know that?
Well, nobody knows that really, but probably that in heart failure, because the mechanism is quite different, you have more sodium retention than what you would have in a patient with pulmonary arterial hypertension. And that could be the mechanism that leads to fluid retention. It's a hallmark, and it's irrespective of the type of ERAs. It has been shown with all the ERAs that are on the market currently.
And it's quite unique for ERAs.
Yes,
not so much for PDE5 inhibitors.
No, it's not for PDE5. Although if you look at the Ambition trial, which has nothing to do with it, the reporting of peripheral edema in the tadalafil group is very high. It's 28%, as opposed to less than 10% in the initial seminal trial that led to market approval. So this is something that we need to look at quite carefully. And then, of course, combined post-capillary and pre-capillary pulmonary hypertension, it's fitting with the new definition. PVR is above 3. It could be in this case that the pre-capillary component has been triggered by PFOs, but indeed we confirmed that this patient had sleep apnea, and that could play a role in the overall picture of this specific case. So 2 conclusions. Similar to CTEPH, the diagnosis of PH due to HFpEF is challenging. There's no overlap with PH, but the distinction between both should be made based on the clinical history. It's not only a question of hemodynamics. We need to look at the whole picture because, again, pulmonary hypertension is not a condition by itself. It's not a disease. In this case, it's a complication of an underlying disorder. Definitely, PH therapies are not suitable for pulmonary hypertension due to left heart disease. We have so far no evidence in any randomized controlled trial that there's any benefit, and there's even now signals showing that it may be associated with significant side effect, even with the PDE5 inhibitors in specific conditions such as left ventricular assist device HFrEF, and valvular heart disease. So those drugs should be used with a lot of caution. Actually, should not be used in pulmonary hypertension due to left heart disease, so the road is blocked ahead.
Thank you very much, Jean-Luc. So I think we've seen 2 very nice cases. Both are pulmonary hypertension, and we have seen that the mechanisms are totally different. The therapeutic consequences were totally different. So it's really important to do a comprehensive diagnostic workup before we make any treatment decisions. Now, this afternoon, we have already talked about the wedge pressure, where should we measure it, and you mentioned in the context of group 2 PH, the clinical picture, which is of utmost importance. Then you mentioned hemodynamics, but I also want to come back to imaging, because we have, and this is actually a question from the audience, in the NICE working group, we were discussing a lot about IPCPH versus CPCPH, a precapillary component. And people ask, is there any therapeutic consequence based on that? We know that it's prognostically relevant. Is there any therapeutic consequence?
Yeah, it's a very good question. The answer is no. At least if we take the HFpEF side, beyond the prognostic implication, the answer is no, because there's no treatment approved. However, there might be one indirectly linked to this, which is to be able to rule out left heart disease-induced pulmonary hypertension in a patient that has IPH and risk factors. So I would say that the therapeutic consequence is probably there. It's a way to rule out, but at this stage, indeed, there's no consequence. Maybe one situation where it may have some consequences, which is heart failure with reduced ejection fraction, because if a patient is a candidate for transplant, you would do a vasoreactivity testing to just to show, in fact, that there's a potential for reversibility of the abnormalities seen at the hemodynamics. And also, it's for us at our center a very good indication for left ventricular assist device implantation prior to go for transplant. So our surgeons are not frightened by the fact that PVR might be high, provided, of course, that the patient has a still elevated wedge pressure on which you can action to decrease the filling pressures. This would be the two therapeutic consequences with this distinction.
Okay.
At the moment.
Yeah, in the future we don't know.
It's a phenotype,
Yeah.
But when we talk about PH and left heart disease, your case focused on HFpEF. Now you mentioned HFrEF. We also have to mention valvular heart disease. Sure. And in the context of HFrEF and HFpEF, functional mitral regurgitation is a quite frequent problem. We have interventional treatment options for that as well that we should consider in such patients, and that can obviously be a cause of pulmonary hypertension. But I want to come back on the simple thing of diuretics. That really helped your patient. And I think considering the small PAP monitors, CardioMEMS and others, they have given us very intriguing data, both in HFrEF and in HFpEF, about the role of diuretics, because they are the main consequence of monitoring PA pressure was an adjustment of diuretics. Yeah. And we have seen recently data from the post-approval study in the US and also from the MEMS-HF study in Europe that were just presented at the AHA, that we reduce the hospitalization rates, heart failure-associated hospitalizations, even in HFpEF, by 60% or something like that. That highlights the critical role of diuretics. And I think that's really an important lesson to learn from these trials, and your case also illustrated that very nicely.
Yeah, you're right, Stefan, to mention that. It's very interesting to see how shy sometimes we are with the use of diuretics, and I think I still can make my head around who should get the CardioMEMS or any kind of implanted device, who would best benefit from that. But what I can tell you...
I don't really want to talk about that, but what we learn about the importance of diuretics.
Sure. So again, that's the key learning. We should really be quite aggressive with using the use of diuretics, using urinary spot, measuring natriuresis. That this is something that we do routinely, surely if the patient is in the hospital, but also for outpatients. It's a great help to make decision to manipulate the diuretics.
Right. And we're sometimes concerned about the kidney, but when you talk to nephrologists, we also talked about that previously, they are not so pessimistic, they're not so concerned. No. And in fact, we learned that when you diurese these patients and you get rid of the congestion into the kidney, that also helps the renal function.
Absolutely.
So important message.
So you need to break the vicious circle of congestion, decreased renal perfusion, acute kidney failure and chronic kidney failure. And this case again illustrates that we should be quite liberal with the use of diuretics.
Right. Perhaps we're getting close to the end here. Short question, short answer. Volume challenge. This is in the Nice manuscript. Yep. So if in your case, patient would have been on diuretics and then the wedge pressure would have been 14.8, what then? So
normal wedge pressure is 12. 12 to 15 is a gray zone. 14.8 is gray dark zone. We would have done a fluid challenge in this case. We would have given 500 mils of saline within 5 minutes and check whether the wedge pressure would go up above 18 to 20 millimeters of mercury. That would have helped nailing down the diagnosis. To be fair, we do not know in the context of pulmonary hypertension what it really means in terms of prognosis and outcome. So we need to be cautious with it. But again, this is a very simple test to perform in a cath lab.
Okay. So what we have seen, it's quite complicated and complex in these cases of you may have HFpEF, you may have valvular heart disease in addition. You also may have pulmonary vascular disease that could be on the venous side or on the arteriolar side, as you have mentioned. And to really nail that down in the individual patient, we've mentioned hemodynamics, we've mentioned the clinical scenario, but I also want to come back to imaging in the end. On echo, if we see a very large right heart and the RV to LV ratio is very high, that always concerns me, then that in such cases it may not really be only due to left heart disease, but then a condition in the pulmonary circulation could be associated with left heart disease. So
Could be.
There's more to come, and in terms of the subclassification into IPCPH and CPCPH, I think we also have to do our homework. So far, as you mentioned, no PH drugs in PH left heart disease, but there are trials ongoing, particularly in patients with CPCPH when the PVR is very high. One example is the ongoing PASSION study in Germany. So I think it's fair to say that in this scenario we still have homework to do. And now we are approaching the end of this webinar, and I would like to close this session by summarizing the key messages for your daily practice, which we have actually already done. But let me summarize that again. We've seen a beautiful case of CTEPH and the therapeutic consequences there. We've seen a rather complicated case of, maybe not so complicated after all, of HFpEF and pulmonary hypertension, again highlighting the different causes of PH. So we've seen very informative presentations, and we also again thank Actelion Pharmaceuticals for kindly supporting this program that was presented to you on behalf of the ESC Working Group on the Pulmonary Circulation and Right Ventricular Function. Now you will be able to watch this webinar on demand on the ESC website, and there are more webinars to come from this working group focusing on pulmonary embolism and other things. But for today, thank you all, see you all soon, and have a great evening. Thank you for attending. Thank you very much.